and introduce yourself. I'm sure you can do better than I can, so go for it.
That's great. Can you see my screen all right?
Yes, we got it.
All right, very good. So I'm Dr. Watts with Biogenetics, and Biogenetics is manufacturer of nutraceuticals in the functional medicine space. And we've been cranking out patient-centric content for, man, I don't know, 6 or 7 years now, but the company's been around a little longer than that. And one of the things that I pride myself on is being a clinician first, because it's all about the person sitting across from you. And so that's really what I want to focus on tonight as we talk about the clinical manifestations of gut-brain connections. And so we're going to go ahead and do that. If you guys got questions along the way, feel free to fire away. I don't have, not sure how to see the chat box window as we're going through this, but I'll circle back when we're done and we can certainly go through that. So if there's something on there, Dr. Clearfield, that needs to be addressed, just let me know. Feel free to interrupt.
I'll let you know. Okay.
All right. So as we go through the process today, just a couple of things I want to talk about. Obviously, FDA disclaimer regarding nutritional products. Some of the things that we're going to talk about today are what I would consider to be common sense for clinicians. And the common sense for a clinician is usually rocket science for the researcher and vice versa. And so one of the things that I want to show you is what's actually happening with these patients as they're sitting in front of you. So we're gonna explore some of the medical literature first, and then we're going to get into a little bit of casework, and then we'll circle back to the medical literature once again. So anyway, this is a graphic that we use at Biogenetics every single day. It's called a root and fruit graphic. We have our practitioners, people that participate with the company, print it off, put it in a picture frame, and put it in your office. And showing patients that their genetics and lifestyle make a difference is pretty empowering. So we have the root structure, which is your lifestyle and environment, and the genetics planted in it gives us the manifestation of a chronic condition. Chronic disease doesn't happen in any other way. The DNA that's there has to be turned on and expressed. Well, it's pretty cool when patients start to realize that, hey, they actually have control over their healthcare outcomes. And specifically as it relates to gut-brain connections tonight, I want to show you some of the back alleys, if we can, as to how that works. So anyway, let's start in on the medical literature with this frame in mind. So keep the root and fruit graphic in mind, and we'll just see where we end up here this evening. But this, we're going to start with something that is from the Frontiers in Neurology Journal in 2019, talking about crosstalk between the gut microbiota and the brain. What they have been proposing specifically in the research is trying to find some objective way of understanding, is this person with the subjective symptoms across from me dealing with a gut issue that's manifesting as anxiety or depression or fatigue or brain fog? And what these people have ended up doing essentially is taking the existing data and boiling it down into a specific protocol that if you wanted to spend the money to discover in a specific patient, they could certainly do that. So it's a variation on MRI and then stool testing and looking at the different connections associated. Now, one of the things that I wanted to do in this research article is not talk about what they've been doing, but what the basis of their research is based on. So the foundation, if we can understand the foundation, we can start putting together some logical sequencing here. So anyway, let's go through a little bit of the foundation, right? So increasing amount of evidence, I won't read the whole thing here for you, but an increasing amount of evidence suggests bidirectional communication. So it's a two-lane highway, typically looked at as the vagus nerve between the brain and the gut and the gut and the brain. Now, what they've discovered is that it's actually a much larger highway than the vagus nerve itself. And one of the things that you'll see in the articles here as you're reading through these, if you choose to do so, is that patients that are dealing with GABA issues and anxiety versus patients that are dealing with potentially serotonin issues and depression, not all the time are we looking at a vagus nerve connection, that super information highway between the gut and the brain. Now, it says alterations or perturbations of the gut microbiota are associated with neurodevelopmental, neurodegenerative, and psychiatric disorders, and modulation of the microbiota gut-brain axis by probiotics, prebiotics, so things like fiber, and or diet. And I think that is a huge and or right there, induces preventative and therapeutic effects. Now, that's the foundation they're starting with. And remember what their job was, is their job was to sort out, can we look at imaging and see if a patient that is only eating, French fries and margaritas, right? Does their brain hold a certain imaging pattern versus somebody that's eating mainly meat or somebody that's eating mainly vegetables? And so very interesting, their findings. They got to the bottom of it, and certainly they have found variations. Now, it says modern neuroimaging techniques and other imaging modalities have been increasingly applied to study the structure, function, and molecular aspects of brain activity in people, right? Which has resulted in increased understanding of the microbiota gut-brain axis. The problem with this is that it's almost not accessible to the general public, right? Who's going to go in? They have, a clinical manifestation of anxiety. Who's going in and getting $5,000 worth of imaging and stool testing? Not a lot of people, right? It's not frontline therapy right now. So what we want to do is understand this is 2019, and this is basically the first talk that I could find of it on PubMed of them developing some form of a functional testing. Now, if we look at the neurological disorders, one of the connections that they found between things like anxiety, depression, cognitive decline, dementia, one of the things that they found between that and the gut is something called hepatic encephalopathy. Hepatic encephalopathy is a very common finding in functional laboratory work. The problem is that it's looked at as a syndrome, right? A spectrum of neuropsychiatric symptoms that range from subtle fluctuations in cognition all the way to somebody being out cold in a coma. Alterations in the gut microbiome, as well as the related metabolomes, such as amino acid metabolites and endotoxins, can lead to the occurrence of hepatic encephalopathy when occurring against the background of something called intestinal hyperpermeability. Well, we would call that leaky gut, right? And I don't like the term leaky gut as much as I like the term hyperpermeability, but that's the term that Dr. Google will tell you about. And so that's what your patients are finding. Problem is that systemic inflammation is a precursor to hyperpermeability, and systemic inflammation is basically ubiquitous at this point in our patient populations. So checking this against a bacteria-driven, so a microbiome-driven, neuropsychiatric issue, right? There has to be a connector. Now, if it's not going to be the vagus nerve, one of the things that I would strongly suggest that you look at in practice from a testing perspective is the liver. So let's go a little bit further here and just connect a couple of other dots before we start looking at the mechanism. So using a combination of cognitive testing, assessments of the patient's stool, brain MRI, and evaluations of systemic inflammation, they identified a robust correlation network in which bacterial families are negatively correlated with liver function and glial manifestations of ammonia in the brain. This is cool, right? What they're basically saying is that if your bacteria and your microbiome looks X, Y, and Z, and we can measure the ammonia situation that you have going on in your body right now, we're going to find a connector, and the connector is likely going to be hepatic encephalopathy. So hepatic encephalopathy is not something that I've ever heard talked about in the functional or integrated space, even though it is the direct connection between diet, gut, and your cognitive function. It's the direct connection. And so oftentimes in integrated care, we pride ourselves on being able to, not be isolationists, okay, not be specialists, going to see the derm doc or anything like that. it's all about the connection. It's about how do we take a patient and look at the whole patient and bring in providers that are specialists in different areas as it relates to the whole patient. Well, this is one of those things that I would write down, hepatic encephalopathy, because as we go through the rest of this evening, I think you're going to see that it has opportunity to draw a lot of connections for you in clinical practice, right? A lot of connections. So the same research group that we just mentioned assessed elderly outpatients with or without cirrhosis and found that elderly patients had an altered gut-brain axis regardless of the presence of cirrhosis. So that means that perhaps it's not a pathological hepatic encephalopathy situation. Perhaps it's functional. Now, when we look at functional labs, because I'm a functional provider, when we look at functional labs, I want to give you some definitions here just briefly. If we're looking at a blood lab, we have a pathology range, which is typically 2 standard deviations from the statistical average, right, of the population in whatever region that's being measured on, which means it's a little different in LA than it is New York or Dallas or Chicago. Well, functionally speaking, what we want to do is base our laboratory ranges off of, instead of a very wide range, we're going to use 1 standard deviation. And if 1 standard deviation is not possible because the range is, 0.2 of a point, what we're looking at is for the medical literature to fill in the gaps. So some of the things that we talk about here, right? Functional liver problems leading to hepatic encephalopathy. Well, the transaminases that we would be assessing are not necessarily going to be outside of the pathological laboratory range.
Dr. Watts,
So,
Dr.
yes.
Watts, I hate to interrupt. Are you moving the slides? Because they're not moving. We're not seeing any
Are you looking at which
crosstalk
one?
between gut microbiome and brain.
Yep. So I'll be shifting it here just in a
Okay.
second. Haven't moved
Okay.
it yet. So I just moved it. Do you see my high-tech graphic I drew you today?
We got it. Yes, you did a good job.
All right. So what these guys are talking about here in this review is that we could have something functional like leaky gut or hyperpermeability, where we're actually seeing the tight junctions between enterocytes gap, allowing products from our diet and or like something like lipopolysaccharides from gram-negative gut bacteria into the bloodstream. Okay. We can go straight from that to this patient has the manifestations of a psychiatric problem. We can go straight to that. Specifically, if we're talking about things that are, driving some form of inflammatory process neurologically. Okay. What I'm showing you here and what I want to show you in the medical literature today and in a case study that I have for you is how this hyperpermeability is actually leading to something called hepatic encephalopathy, which is ultimately driving a larger fire in the central nervous system, as one of the main clearance organs of the body isn't doing its job, right? So we're going to talk a little bit about detoxification and the gut today, because as we look at detoxification, we have your liver, your kidneys, your skin, and your lungs being the main detox organs that we're dealing with. But if the big driver, the liver, isn't doing its job, and patients are sedentary, typically, let's say, your lungs, which are the largest detoxifier in the body, are not being put to work, okay, we end up in a situation here where the manifestations of, it could be any neuropsychiatric issue, but typically what you're going to see in my style of a functional practice is going to be anxiety, patients that are dealing with depression through cognitive decline, right? So we don't typically, in a natural care setting, which is what I'm in, we don't typically see a lot of the multiple personality situations or anything like that, but we do see tons of the functional disorders. All right. So anyway, so we can go from gut to brain right away, as we talk about 70% of the serotonin that your body makes being made in the enteric nervous system, a large percent of the GABA that your body makes being made in the enteric nervous system. We can certainly draw that bridge. And that's what most clinicians are going to try to do because it's fast and it gives you something to do. But before we have something to do, we want to have something to understand. And that is this hepatic encephalopathy bridge. Okay. So anyway, So let's look at this. Hepatic encephalopathy is a reversible syndrome. I think that's the key word here, is reversible, of impaired brain function. Now, for the most part, when people are going to seek the help of some form of, psychiatrist or somebody that's going to be looking at their cognitive function under the microscope, so to speak, typically it's not going to be looked at as reversible. And if hepatic encephalopathy is driving it, I think that you should have a little bit more hope for that situation for them. So anyway, happening in patients with advanced liver diseases is what their position is here. The article we just looked at says doesn't even have to be cirrhosis, right? So we could be talking about fibrotic changes, and those happen long before. So the precise pathophysiology is still under discussion. We're going to explore some of that today. And the leading hypothesis is the role of neurotoxins, impaired neurotransmission due to metabolic changes in liver failure, changes in brain energy metabolism. I think that is a huge one. And systemic inflammatory response, alterations of that blood-brain barrier. So what they're basically saying is anything that causes inflammation could be driving this. It could be anything. And I think that's cool because as a detective, as a clinical detective, I want to take what the researchers are finding and I want to see how does it relate to my patients, right? How does it relate? So this hepatic encephalopathy produces a wide spectrum of non-specific neurological and psychiatric manifestations. Minimally is diagnosed by abnormal psychometric tests, right? Clinically overt hepatic encephalopathy includes personality changes, which I said in my style of practice, I'm not going to see a lot of that because usually those people are being captured by the medical providers, right? That are, those frontline therapeutic investors there, right? And minimally, right, is diagnosed by psychometric testing. Clinically overt, you're going to see it personality changes, alterations in consciousness. This is actually something that is debatable, the consciousness part. Most people go home at 6 o'clock and alter their consciousness. Okay. Is that a hepatic driven issue? Well, could be. All right. So just a heads up on this, right? Alterations in consciousness, disorientation in time and space, stupor, and finally, people that are into full-blown coma, right? Except for clinical studies, no specific tests are required for diagnosis. I think this is the key. Treatment of overt hepatic encephalopathy includes supportive therapies, treatment of precipitating factors. I think that's where we as integrated providers could stand in the gap big time for these people. And routine treatment for minimal hepatic encephalopathy is only recommended for selected patients. I think that we need to change this. So one of the things that I hope you do by the end of this today is when you see somebody that's dealing with anxiety, instead of looking at like a socially driven anxiety situation, what I want you to think about is perhaps it could be a toxin driven anxiety situation, right? Toxin driven. So let's go on to the next piece of the puzzle here. All right, this is from a food journal, Food and Function, in 2018, talking about gut, liver, brain axis and the microbial challenge in hepatic encephalopathy. All right, this is where it gets interesting to me anyway, as a health detective. Here we have strong evidence that pathogenesis of hepatic encephalopathy is linked to dysbiosis, right? The gut microbiota, and to harmful microbial byproducts, such as ammonia. Well, we read that in the first study. Indoles, oxindoles, and endotoxins, like lipopolysaccharides. Increased concentrations of these toxic metabolites together with the inability of the diseased liver to clear such products is thought to play an important patho-etiological role. Current first-line clinical treatments target microbiota dysbiosis by decreasing the counts of pathogenic bacteria. The only way that you're going to see that is if you're actually testing the stool, right? So that's something that would strongly be considered here for these patients. Blood endotoxemia and ammonia levels. All right. What they basically are going to do is they go through the process in this review, which is actually a pretty interesting review. They go through the process and show you the specific bacterial concentrations that are present that can drive that from a microbiome first viewpoint. And then they also show you some food-driven genetically, such a genetic response to the food that's taken in the environment. So remember, lifestyle plus genetics giving you a chronic health outcome. Well, if we have a change in that food stuff, like maybe there's a problem as it relates to what's in the food or what's on the food, not just the old trope of gluten causing leaky gut, but basically asking, is the food toxic in its own nature? Okay, so I think this is interesting. Nevertheless, strong effort should be made to increase the information on gut microbiota ecology and its metabolic function in liver diseases. I think I agree with that strongly. Okay, so what I want to do is I'm going to show you a 65-year-old patient here. 65-year-old patient. This is a diabetes patient, and this patient is on insulin. Right, I think they're on Humulin, I believe. Let me just check real quick. Yep. All right, 35 units of Humulin. And then that's per day. And then we also see them on metformin and Januvia. Right? We also see this patient on statin medication, rosuvastatin, and this patient also has hypothyroidism. So they're on levothyroxine. So this is a 65-year-old. And what we wanted to do here is understand what's in this patient's body that's not supposed to be there. Like understanding that diabetes as a protective mechanism that staves off cell death, right? Remember, your brain is built for like 120, and it's going to do everything it can to make decisions around that. Even if that means functioning at 30%, being 80 pounds overweight, tired, brain fog, depressed, your brain would rather be all of those things than dead. And so what it does is it decreases cellular function so that we can drive insulin resistance as a protective mechanism. Okay. So that's a background here. Now, we want to know what's in this patient's body that's driving reactive oxygen species production other than just maybe too many carbohydrates. Right. Well, this is a sample of a tox panel that we ran on this patient. And this is from a company in California called Vibrant Wellness. And it's a part of a total tox panel. So we're checking for environmental toxins, things like phthalates and pesticides, herbicides, volatile organic compounds like the stuff coming out of the tailpipe of your truck, mycotoxins, which is what I'm going to be interested here with this patient, and then heavy metals. And this is a urine sample. So this is not looking at full spectrum, right? What like load? This is looking at clearance. So this is looking at what is the patient able to clear currently. So just because the heavy metals are negative here doesn't mean that they truly are negative when it comes to total tox level in the body, right? So just something to note there as we're going through this process. Now, what we have here is glyphosate. That is ubiquitous in almost all diabetes patients. You're going to see a signature of glyphosate. I bet you this year I've probably looked at 1,000 of these tests, and I can probably count under a dozen times where a diabetes patient has come back without glyphosate in their urine. Right? Really interesting. Parabens are in personal care products. These are typically things that are just taking up bandwidth in the liver detoxification pathways, certainly with the kidney, as you see here. Other metabolites that we're talking about, just so we can get these off of our plate, diphenyl phosphate, something that is carcinogenic and certainly going to contribute to the patient's cognitive function. And then volatile organic compounds, these directly on their own can create encephalopathy. This patient was dealing with neuropathy, right, bilateral in the feet, as well as symptoms of depression. And it was undiagnosed, or I should say unmedicated, but symptoms of depression and anxiety. So the methylhippuric acid compounds here, these can certainly contribute to that encephalopathy on their own. Now, this is what I want to zero in on here is the mycotoxins, where we're looking at aflatoxin, ochratoxin, which is coming from aspergillus, and then the bottom one here is diacetoxyserpinol. Diacetoxyserpinol is from a family called the trichothecenes. Trichothecenes are typically going to show up in grains, right? So if it's growing in a field and it requires water to grow, that is going to have trichothecenes associated with it. The problem that comes into play is when trichothecenes get into the body and what they actually do. So we're going to explore this a little bit here. We'll come back to this patient case in a second, But I want you to remember diacetoxyserpinol here. And then there's another one that I want to talk about called nevalinone, right? Nevalinone and DAS. These are the big dogs. So if we look at the values here based off of Vibrant Wellness's, just the algorithm that they're using here, diacetoxyserpinol, you can see is the third one from the top from the fusarium family. Again, showing up in grains. We don't want to be over 3 and change, and we're at 18 and change. And just in general, patients are developing symptoms associated with these mycotoxins, anywhere between the moderate elevation category and the high end of the lab range. Okay, so just throwing that out there. Diacetoxyserpinol, well, oftentimes patients are going to be concerned about mold coming from their homes. This is the big one. This is the daily exposure, right? This is like an everyday situation. I live in Minnesota, like the land of corn and wheat. And this is something that industry is built around in Minnesota. Okay. Industries are built like General Mills, Post, all of these massive companies have spent tons and tons of money to figure out how to grow grain without the grain producing fusarium or with the grain being resistant to the fusarium itself. Right. So this is a really interesting topic just for my neighborhood here. All right. Here's a patient's glucose content, 188 on a fasting sample. Look at the metabolic acidosis starting to show up here with the carbon dioxide content at 19. That's interesting. And then we start to see albumin content creeping up, total protein at 7.9. And while it's not diagnostic of, it is certainly consistent with a patient expression of leaky gut, right? So the total protein content upper end of the 7s there. Now notice it's still within the laboratory range. The pathology range, the reference interval goes up to 8.5 grams. And so functionally speaking, we like to see that below 7.5, above 6.5. So, all right, we see elk phos is low. Interesting. And then the transaminases here, 2 of them anyway, AST and ALT, we like to see those between 12 and 26. This reference interval goes up to 40 and 44. And for the most part, what you're seeing with this is a gentle liver stress. That's how I would look at this, right? Are we expecting this patient to have massive cirrhosis? No, not at all. Okay. In fact, most providers are not ever even going to give AST and ALT a second look, considering that they're not emboldened there. Right here we have their A1C at a 9, right? And this patient's already on the end of the treatment plan. They're already on insulin, Humulin, I believe. Yep, Humulin. And that's the end of the treatment plan, right? So from here forward, the doctor is going to be manipulating the dose of that based off of the patient's performance. Now, the patient's told to diet, lose weight, and exercise, right? Which they probably should be trying to do. Additionally, look at the triglycerides that they have going on, 336. That is a robust triglyceride load here. Okay, so just some interesting findings with this patient case thus far. Right now, remember, we had trichothecenes. Trichothecenes, right? Trichothecenes are from fusarium. So when you see laboratory reports that show you things like mycotoxins, what we want to do is follow that train of thought to its end. And the end here happens to be hepatic encephalopathy. Okay, so let's take a peek at a couple of things here. The trichothecenes are the main fungi species that produce, or excuse me, fusarium is the main fungi species that produces trichothecenes. Right, this is something that you're going to find in grain, as I mentioned. Side note, I thought this was interesting for anybody who's a history buff. During World War II, a biological weapon caused an acute syndrome consists of cough, sore throat, dyspnea, bloody nasal discharge, and fever, reported by Soviet scientists. Right, 20 years later, mycotoxins, T2 mycotoxins, which are from the trichothecene family, discovered when civilians consumed wheat that was unintentionally contaminated with fusarium. Toxicosis due to ingestion of moldy rice contaminated with T2 toxin has been reported in China. All over the world, they have this problem. In fact, I have a slide here to show you in a second where it actually shows the trichothecene content of the grain in various countries. and what we're actually dealing with. Okay, so check this out here. Trichothecenes, toxic signals include decreased plasma glucose, right? Decreased plasma glucose, reduced blood cell and white blood cell count, weight loss, alimentary toxic eleukia, so we have tons of vomiting and rupturing and swelling, as well as pathological changes in the liver and stomach. The mechanism involved, right, in T2, and this is navalonol, deoxynavalonol, DON, toxicity is generally via oxidative stress mediated damage. Oxidative stress. So remember when we talked about diabetes patient where they breathe in oxygen, they eat food, they mash two together, they get ATP, they exhale CO2. The side effect of that is creating reactive oxygen species. And as reactive oxygen species begins to build and the body can't keep up with the ROS cleanup effort, it's like metabolic dust, that cell begins to become insulin resistant to prevent more energy from crossing the cell membrane and furthering the ROS buildup. Right? So if this mycotoxin can produce the same effect locally on whatever cells it's exposed to, but then systemically, we got to think about this as potentially a diabetogenic effect on this diabetes patient. Anyway, furthermore, these guys are well-known inhibitors of protein synthesis resulting from binding of the peptidyl transferase, which is located in the ribosomal unit. All right, so this is really curious because if we have a mycotoxin that's showing up in our food supply, right, and regardless of the glucose content of that food supply, it could still act as a diabetogen. I think that is interesting for these patients that are trying to, do their best on the diet, lose weight, and exercise plan. Right, so in the GI tract, a decreased absorption of glucose was observed following intoxication of these mycotoxins. Right? That's in and of itself, that is stunning. Right? Apart from the glucose absorption, right? SGLT1, this glucose transporter, is responsible for water reabsorption as well. And so that means that this patient ends up with diarrhea. Okay, so when we have patients that can't go to the bathroom without their bran flakes in the morning, is it just because of the bran, or is it possibly because of the mycotoxin content of the bran as well? Right, so just something to consider. The weight loss effect of trichothecenes involve neuroendocrine factors and cytokines. Cytokines, this is where we start getting into the inflammatory situation associated with the liver as well. The neuroendocrine factors associated with the weight loss can affect secretion of both anorexigenic and or orexigenic hormones. Through increasing gene expression, anorexic-inducing pro-inflammatory cytokines such as interleukin-1 beta, interleukin-6, and tumor necrosis factor alpha. TNF-alpha gets secreted or expressed rather because of these mycotoxins. TNF-alpha is like the fuse for the inflammatory dynamite systemically. TNF-alpha, that is an interesting one to highlight, right? Trichothecenes exacerbate the condition of anorexia. In addition, these mycotoxins also induce the release of satiety hormones. This is really interesting. So one of the things that we have going on right now in the functional world is you have a bunch of kids going back to college. And college kids, notorious for gaining their freshman 15. But what if they don't, right? Keep an eye on that. It's maybe not just like psychologically induced anorexia. I've had a few cases in the past week come across my desk that this is what we were looking at, which is why I was happy you guys want to talk about gut-brain connections here, okay? So very interesting. All right, continuing on here. Using animal models, trichothecenes are found to induce necrotic lesions in the GI tract. Now, we're not just talking about, driving up zonulin content and those tight junctions between enterocytes being not so tight anymore. We're not just talking about this like 4-step chemical interaction here. We're talking about trichothecenes themselves creating necrotic lesions in the enterocyte. All right. This is really curious because we would traditionally look at things like gluten or actual IgE mediated allergies as driving this type of a response. That would be a typical, more acceptable thing to talk about. But if we're talking about mycotoxins showing up, piggybacking on these grains, ending up in the patient's sandwich as being the driver of that, how are we ever going to find that? Right? How do you test for that? It doesn't look like you have celiac. Okay. However, every time the patient eats that specific sandwich from that specific company, right, we end up driving the anxiety effects. We end up driving the brain fog, and we end up driving the GI, the distension or the diarrhea that shows up with it. I think it's pretty cool. Okay. I think this is pretty cool. Anyway, furthermore, right, the results obtained from studies here in the body and out showed that trichothecenes increased intestinal permeability on their own. Using porcine epithelial cells, trichothecenes increased the intestinal permeability by lowering tight junction protein expression. Right, lowering expression. These people found this in 2013, which means we've known about this for over 8 years, and it's not made its way into functional offices yet. Right? Not yet. The disruption of the integrity of the intestinal epithelium allows the entry of the pathogen into the gut, obviously, and the trichothecenes end up right in the intestine, responsible for pathogen removal. This interleukin 8, not happening. Okay, not happening. So trichothecenes in the gut, not the plan. When we look at the grocery store, the question that you got to ask yourself is, well, obviously nobody would go and grab a clump of trichothecenes that are growing, okay, and just eat it like an apple. Nobody's going to do that. Okay, so is there an acceptable level that we find in the grocery store? Is there an acceptable level? And it turns out, yes, there's an acceptable level. And so when you see the wall of food that was, 6 months ago in the field, you gotta think about what kind of content, not just from a carbohydrate or protein perspective, not just macros, but what kind of content are we driving that's going to end up funding and fueling the latest 46-year-old, working mother, her anxiety, right? What is it? Is it just that she's a 46-year-old mother with teenagers, or can we have a situation showing up? This is from a different study, and I didn't have space to put the slide for the study on here, but the link is at the top. If you punch in the PMC number, you can find this exact one, okay? What I wanted to show you here is a breakdown. You got food in the feed matrix on the left. So you got things like barley, corn family, rice, wheat grains. And then I want you to see in the middle of the slide, it says percent positive samples. Percent positive samples. And there's screening here for trichothecenes in the food and feed samples. Okay, so this is food and feed samples, and this is I just screenshotted the A through G here for you. Okay, so, and we're looking at these trichothecenes specifically. So at the top, let's actually go to wheat. Poland, Polish wheat is a huge one, huge export. Okay, 83% of Polish wheat showing up with trichothecenes present. The trichothecenes themselves can live on the outside, the hull, and they will also weasel their way in to the seed. Okay, and in this type of a situation, if the farmers leave the field, tall for too long, like right now, they're just getting ready for harvest season in Minnesota. I saw a few rows of it today. If they leave that out for too long this fall, okay, they risk this dry rot showing up. Well, that's trichothecenes. Okay, so check this out. Here is another one where we're looking at pasta and noodles in Germany, 97%, right? 97% positive samples. Like, this is kind of surprising when you start thinking about trichothecenes driving leaky gut, right? And they're piggybacking on foods that people have been blaming for leaky gut. And so the question is it really the food? Like, have we potentially given gluten a bad rap, right? I'm not saying we have. I'm just asking the question. Have we done that? Maybe not, right? So a couple of other things here that I wanted to show you. Due to the significant health implications of trichothecene exposure in humans and animals, limits are placed on the allowance of trichothecenes in different food and feed products. Well, that's cool. Okay. So we see that. North American and European guidelines for trichothecenes in human and animal food differ, both in terms of the acceptable concentration, limits, and the specific affected commodities. Okay. When I read this, I almost fell out of my chair. Okay. So here we have finished wheat products for consumption by humans. This is what's allowed in the USA, 1,000 parts per billion. Right. So just from the toxicology samples, and these are trichothecenes now. Right. And we see these are 1,000, 2,000, 500, bread, biscuits, pastries, cereal, snacks, breakfast cereals in Europe, 500. Okay. 500. 500. How come Europe has a higher standard than we do right now? All right. Now check this out. This is for feed. This isn't for people. This is for feed. All right. This is for feed. What are we allowing here? 10 parts per million now. 10 parts per million. Okay. This is interesting. The reason that this is so interesting is because the food allotted for animals has a tighter window of acceptable trichothecene value, right? The food for animals. All right. One of the reasons why I think this is so important is because this is huge industrial ramifications. You don't want a herd of cattle that you've been feeding corn or finishing these beef cattle with corn. You don't want all of them developing necrotic lesions in their gut and dying in your field. Okay. That would prohibit the profit. Makes sense, right? Prohibit the profit. Okay. Now, the problem with this is that trichothecenes that contaminate cereal-based food and feed have devastating impacts throughout human history. There's a study earlier that showed there was a contamination 100 years ago in Europe, right? One of the studies I cited earlier, that 176,000 people died because of trichothecene exposure. Okay? I think that's incredible. Well, the ability to monitor and limit the entry into the food and feed chain has improved. It continues to persist. Significant economic impacts as well as health and safety risks. The pathogens continue to evolve. Now, here's the problem. We can craft and create all of these awesome herbicides and pesticides that control fungus, etc., but these things are adapting and these things are growing stronger in their effect. Part of the reason that they're growing stronger in their effect is that, like I have kids right now under 10, 3 kids under 10. And what these kids are eating is not like what I grew up eating, and certainly not like, some of the docs that are on the webinar here grew up eating. Because I see that some of you are probably in your 50s and 60s. Okay. What you grew up eating is a completely different animal than what these kids are dealing with right now. And I think it's just incredible to understand that if we're looking at a enteropathy situation that can be driven by an acceptable amount of trichothecenes in cereal grains, right, that can end up leading to this whole host of issues that we're currently dealing with right now in this childhood scenario: ADD, ADHD. Right? How many of these kids are also dealing with psychosocial issues as it relates to self-harm is a big one, right? Just a big one, especially with kids that are in middle school and high school. So what I would encourage you to do is to think about these cases and to strongly consider checking your patient population that you're seeing for mycotoxins, right? Once again, this is, maybe Kim, you could drop this in the chat box, but this is from Vibrant Wellness, and it's something called a total tox panel that's helping us identify trichothecene involvement in these patients, okay? Among other things. Now, cereal grains. So what does that mean for these diabetes patients, right? Am I asking them to go grain-free? 100%. At least I'm asking this person to go grain-free. They got diacetoxyserpinol, trichothecene that comes from wheat and corn products showing up in their urine. right? And that's just, again, a reflection of what their kidneys are willing to get rid of, not giving you the full scope of what's actually present. My goodness. So we're definitely getting rid of grain products for this type of a case, right? Are they going to be happy about it? Probably not. Is it about the carbohydrates for me? Nope, it's not. This is specifically driving reactive oxygen species production and apoptosis. That hits the liver, right? And the liver is now handicapped and can't clean this stuff out, but for the patient, as far as detoxification is concerned, and we're left with the side effect of it. So just once again, taking a peek at this, in your patient base, you would start to put the A plus B equals C together, right? If you ask this question right here, what's in my patient's body that's not supposed to be there, right? If you ask that question, you are bound to find an answer, okay? What's in this patient's body that's not supposed to be there? That's what you want to find out, right? Root and fruit. Yes, they're showing up with cognitive decline at the top of the tree here. Yes, right? That's a fruit. Modern medicine exists to medicate the heck out of the fruit, right? Suppress it, downregulate it, block it, inhibit it, whatever we can do for that symptom, that complex of symptoms, whatever we can do to make those go away, that's what we're going to do. However, this tree is going to continue producing inflammatory based disease, right? Because that's what's in the DNA. And if that DNA is planted in an environment that's loaded with mold, right, or heavy metals, whatever it might be, in this instance today, we're talking about mold, right? We are going to continue to manifest that chronic disease. Now, the way that you chop this stupid tree down is by controlling lifestyle and environment. It's by controlling the patient's nutritional intake. Those are the only two things you got to control, right? Nutrition and their environment. If you can do that, you're going to harness that power in their body that heals the edges of a cut together, right? Especially if these are young patients. I mean, this 65-year-old diabetes patient, I would expect their A1C to be back under 6 within 6 months, right? Their medical provider is going to have to scale down their insulin use over time, slowly, okay? But as insulin sensitivity returns, because we're vacuuming up that reactive oxygen species, okay, with antioxidants, et cetera, and we're stop lighting the body on fire, right? We would expect that patient to move in the right direction. So hopefully this is making sense. But when we look at gut and brain connection, I want you to look for a connector, right? I want you to look for a connector. It's too easy for a patient with anxiety for us to say, yes, we're just going to give you a probiotic. It's too easy for a patient that has symptoms of depression for you to just give them a probiotic. We want to find the connector, find the mechanism. And if we can find the mechanism, then we can help create health for life. That's the goal. So anyway, what I would like to do is, if you guys would like to, we got about 8 or 9 minutes, I guess, left until the top of the hour. We can certainly discuss, any questions that you might have or anything that you want to talk about, Dr. Clearfield, on top of that.
Okay, well, we don't, if you have more to go, most of our folks are more than happy to hang around. So, but if anybody has any questions, I don't really see anything in the chat. So,
okay. So what I'm going to do is pull up a secondary slideshow that I was building here for you. Okay.
Okay.
And I'm going to just pull this guy up here. I'm going to show you a couple of mechanisms that, as it relates to what we're working on. All right. So I'm a clinician. I'm a teacher at heart. All right. I'm a teacher at heart. And so I want to give you a little bit of what that looks like. All right. So you hear high-tech graphics coming out of out of my computer here for you today. So here we have these blue stars. I want you to think of these as glucose in the bloodstream. Okay. Glucose has to cross the cell membrane into the cell so that you can have all of this mitochondria, whether it's glucose or, fatty acid oxidation, as whatever you like to think of it as for this example. You're going to mash it together with oxygen and you're going to develop some ATP. Here is all of that free radical damage that's increasing. These are the electrons that are supposed to be shunted to the electron transport chain, right? This is piling up, which means our ETC is running out of the ability to handle the load. Well, free radical damage starts blowing holes in the side of your mitochondria. The membranes begin to rupture. As those membranes rupture, right, this cell becomes at risk. Here's where that insulin resistance is showing up for the patient. Okay. So here you have the cell membrane developing insulin resistance and resisting the glucose now crossing that cell membrane. When we look at this mechanism here, this is saving lives across the United States right now. 10% of the United States population is dealing with type 2 diabetes, 10%. This is a life-saving mechanism. The problem is that if we don't ever do anything about the ROS or this glucose, the glucose ends up wrecking people's lives later on as well. Okay. So as you're seeing this, what I want you to think about, go ahead.
Are you showing a different slideshow? We're seeing your
Yeah.
fruit tree.
All right.
We have your
All right.
the tree and fruit.
Yeah, let me
We
get
didn't have
you
that.
here. You
There we
gotta
go.
you gotta put the, you see a different one here?
Yes. Mhm.
Okay.
Sorry
All
about
right. I apologize for that, doctor. So
that.
here you have the glucose crossing the cell membrane into the cell, and we end up creating ATP and free radical damage results. This free radical damage, right, is electrons that are supposed to be consumed by the electron transport chain, which is in the middle of the mitochondria here. That's not happening, right? And so what we see is that insulin resistance starts to take place where this cell membrane begins to become resistant to this glucose crossing, right? So we end up with insulin resistance showing up here. And to the extent that this reactive oxygen species is cleaned up is to the extent that the glucose ends up coming back down later. Right now, this patient with a 9 for an A1C and they're averaging 212 according to LabCorp for their glucose content, right? They have quite a bit. They'd be looking at a situation like this, okay? And as we're looking at this glucose beginning to pile up, the insulin resistance is piling up. It's a protective mechanism, but the doc's giving them Humulin, right? And what we're doing is essentially forcing this to take place, right? Where the glucose is crossing into the cell, all right? We're forcing that to take place. That's exactly the opposite of what the body's trying to do. The body is trying to avoid glucose entering the cell because of this free radical damage. Now, if you can vacuum this mess up, right, and we can stop producing or consuming products that drive reactive oxygen species, like trichothecenes, right, you would expect that these glucose situations begin to chill out. And as I mentioned, this patient, you would expect that their glucose is near normal, right, in about 6 months. So sometimes people make it interesting, but near normal in about 6 months. Now, what you get as you're cleaning up the reactive oxygen species is this cell membrane chilling out as far as its sensitivity to insulin. Patient's need for insulin starts going down, right? And for the most part, these patients are still producing insulin out of their pancreas. C-peptide values are relatively normal for these patients that are new to insulin, okay? So I think that's an interesting concept as it relates to the trichothecenes, especially because these patients are specifically, these patients are eating whole grains, right? That's where it's coming from. These patients are trying to control inflammation by following what the recommended guidelines are right now. And, for some people, I feel that the recommended guidelines need to be escorted to the trash can as it relates to the whole grain situation for them, especially this chronic disease crowd. So the chronic disease crowd is interesting. Now, here's something I wanted to show you here as well for trichothecenes. This is a graphic showing glutamine, an amino acid, and going through a synthetase reaction where we have glutamates or glutamic acid, okay? Glutamate. Glutamate's an excitatory chemical compound. As a neurotransmitter, glutamate is excitatory. So when patients are dealing with a vitamin B6 need, right, they're not able to use glutamic acid decarboxylase to create GABA out of glutamate. It's a B6 dependent reaction right here. Now, the reason this is important is because trichothecenes block the vitamin B6 content, right, of your diet. Right, that'd be worth writing down as far as clinical content here. Vitamin B6 and trichothecenes, super interesting. So what you end up with is a patient that is loaded with trichothecenes because they're addicted to Doritos or whatever they've been eating, and their glutamate activity has been ramped up. These patients are also, watching news broadcasts that are driving their psychosomatic issues as well. And so here we end up with large amounts of anxiety in typically a female here, in this instance, and it has to be medicated. And unfortunately, most people are medicating that, with alcohol at the end of the day, as I mentioned. So one of the things that we want to think about is that this B6 dependent pathway go a long way for helping your patients that you find mycotoxins with, giving them B vitamins specifically. Okay. So anyway, let's do this. Just wanted to give you concept of something that we call the wedge. Okay. And so ask earlier, how do you chop this tree down, right? That root and fruit graphic. We create a wedge. Patients get better in the wedge. All right. And the wedge is controlling the top arm, nutrition, and the bottom arm, right, is controlling environment. If you put a patient through the wedge, controlling nutrition and environment, it looks like this: lab testing, diagnosis, intervention, lab testing, diagnosis, intervention, lab testing, diagnosis. You are constantly combing through this patient's physiology based off the laboratory findings. And the further they get into your treatment protocol, right, the further they get into this with you, right, the greater the results are. It's astounding what the body is capable of when we relieve it of problems. It's astounding. Now, retest the lab every 60 days. That's a rule, right? In my version of functional medicine, that's a rule. 85% of patients are going to improve with basic structures, meaning if you have trichothecene involvement and anxiety and perhaps some other condition, let's let your gut rest. Don't have any grains for 60 days. Okay. 85% of patients are going to move in the right direction just with dietary recommendations. It's amazing. Okay. It's amazing. We start with general recommendations and you fine tune it over time. And what you see is exactly this: the patient's ability to heal ends up moving toward wellness the further they go into the wedge. This is what biogenetics teaches, by the way. This is what Dr. Clearfield was mentioning as it relates to creating clinical protocols for patients. This we call the wedge. It's something that you can get exposed to if you guys would like on something we call Casual Friday. Casual Friday is our webinar series that we participate in, where we get our integrated group of practitioners together and we go ahead and problem solve. And usually it's more casework than straight literature like we looked at today. But the point is that happens on Fridays. All you got to do is get a hold of Kim. If you want access to that, she'll get you set up with your free access to all of the recordings, or you can show up live, whatever you prefer. But I think what we'll end up doing here, Dr. Clearfield, is wrapping it at that for today. So thank you.
Thank you so much, Dr. Watts. And
Yeah.
I was just about to ask Kim to put your contact information. So it's here, kim@biogenetics.com. It's in the chat there. I'm a big fan. I'm on there as much as I can. I wish I had more time. But I've learned so much from you, and I thank you a lot. For all you do, how you do it, and now you tell us you have 3 little kids too.
3 little kids.
Oh my God!
I know. I raced back here from gymnastics practice, so I'll. We're done here. I'm gonna go.
I remember those days.
Destroy the house. So.
Okay. I remember those days. So, anybody have any questions? What do we have here? We got 3.
Yeah, I see the chat box now that I closed the slide. So I'm going to go through and see what we got.
The link to, this is the link here to Casual Fridays right here, kim@biogenetics.com. Okay.
So Kim mentions here also, we do case reviews at Biogenetics. We call it the CC team, the clinical consulting team. Providers from around the country send in their cases And we go through a screen capture review for you of whatever data you send in the patient case, and then connect it to the literature and show you a way forward. So create custom protocols for patients as they
Wow.
go. So,
Okay, is there a charge for that?
no, that's a free service from Biogenetics.
How do you do
So
this?
this year, I think we've gone through almost 3,000 cases.
Okay.
I think it was either 10 short or 10 above. I can't remember, but
Mhm.
we're close to that.
How big a team do you have?
Kim, how many people do we have working out here now? I don't know. I
We
think we got
have
8 or
9.
10 people that we're working on here. So,
Yes.
and
Mhm.
we're always adding consultants in and that type of thing. If that's your jam, by the way, where you like doing case reviews and you like the functional side of things, Biogenetics is always looking for people to participate in that to help serve the functional community. So
Personally, it is, but at the moment, I'm sort of stretched out. So,
yeah, anybody that's listening, if that's what
right.
you guys like to do. So yeah.
Okay. Okay.
All right.
Anybody else? Dr. Watts, always fascinating. And
Yeah, we have a question here. Dr.
okay.
Gerber.
Dr. Gerber. We can't hear you, Dr. Gerber.
Okay. Guys hear me?
Yep.
Yeah. A couple, do you have any direct treatment to kill trichothecenes?
Yep. So what we do is we go through something we call a metabolic clearing phase. And so there's a couple of steps to it. Kim can send you a link to that. And there's a walkthrough with video. I'm pretty sure I'll be the one on the video showing you. But she'll send you a link to that if you request it. And it's the way that we would essentially start the body's ability to detox those things. And then avoidance is going to be a key for that patient until their microbiome is back on top of the situation.
And what are some common mycotoxins in alcohol?
Well, trichothecenes are going to be one of them that you will see, especially in brewed alcohol. Right. So we think of the beers and stuff like that. Stachyboitrys is another one that is very common. Plug your ears, everybody, in wine. So if that's you, I apologize, but Stachyboitrys is massive in wine. If you've ever spent time like in Napa or anything like that, they talk about vine rot, and that's actually a form of Stachyboitrys. So, and you'll show up obviously in the wine crafting as well. Those are the big ones.
Is it in just grape-based stuff, or how about like sake, rice-based?
Also in rice-based products. Yes. Yep.
Thank you very much.
Yes, sir.
Somebody asked, what about kombucha?
Yeah, that's a loaded question because it depends on what your current microbiome is like and what strains of bacteria you're introducing into it with the kombucha. So as far as, mycotoxin involvement, yeah, there is. And also that's part of the feature, not a side effect like it is on grain, part of the feature.
Okay. And Kim wrote more information on the 20-day, 1-day metabolic clearing program to please email her. And
we have one here. It says, do you use binders? Yes, we use a variety of binders, and that's part of that 21-day programming that Kim is mentioning. Yes.
How about itraconazole?
Yeah. So where you have an advantage that I don't is being able to use products like that. So lots of interesting research. Use it as a jumping off point in some of these links. Like if you go to PubMed and you click on, some of the links that were in the review tonight, they'll have a cited by section, and there'll be a ton of people that are interested in that as well. So in the cited by section, you'll find tons of drug information and follow-ups, medical management.
Thank you.
Yes, sir.
Thank you.
Interesting caricature behind you, Dr. Gerber.
Yeah,
On
I
the
was
wall
impressed
there.
by that.
Who is it? I don't know.
It's Dr. Burgess. What about cystis T? Entero S gel. You know anything? CYSTUST?
Yes. So I don't know about the Enterogel, but the cystis T or the cyst T, there are many different herbal remedies that can be used to dampen the effect of mycotoxins as they enter the gut, and many. So like Chinese medicine, the amount of research that's out there regarding the different, herbs, et cetera, that are available is massive. One of the things that I have found is that for the most part, when patients have the manifestations of chronic disease already, like this gentleman we were looking at tonight, when they are that far down the road, they, for the most part, are going to require something that is more than a single nutrient, single action, or they're going to require something more than an addition into their lifestyle. They're going to require, in my opinion, a pretty big intervention as far as, look, your lifestyle is killing you, and this gentleman's already 65, a lot of life left in him if his brain's made for 100. But at his current rate with a 9.0 A1C, the medical literature would suggest he's not making it to 100. So big intervention would be necessary there.
Okay, anybody else have any comments, questions? ENTEROSGEL. I'm not sure what that is, so I don't know if you know what that is.
Let me check that out here for you.
Next question would be, while you're looking, do you think a biodynamic organic winery would be less susceptible?
100%. So I almost suggested that, but I didn't know if that was the place for it today.
Oh,
So,
you're among friends here. So.
okay. Oh, Entera gel. I got you. Enteris gel is an absorbent. Gotcha. It's an absorbent. So yeah, that would be something, basically covering microvilli with a gel, like a lacking mucus, right? So the body decreases its ability to create intestinal mucus. This is a fix for that. So
I don't know if you covered this in 2 or 3 minutes or less. Can you just briefly describe your 21-day program?
Yep. So
What
it's
does
an
it involve?
elimination. It's an elimination diet that is anti-inflammatory, working with specific herbs that are driving increased detoxification, phase 1, 2, and 3 liver detoxification. And then it pairs it with antioxidants so that we can start vacuuming up reactive oxygen species and repairing the tissue that's been assaulted, and whatever the chemical assault is. So, which is important to note that it's tailored based off of a patient lab, right? So just, giving it to everybody, you could do that if you want, but my style is to look at the labs and make sure that we're tailoring it specifically for them.
Okay. Probably the hardest, we can get a lot of folks to go through these like a 21-day tox. But what do you do after that? That's the hard part.
That's the hard part. That's what the wedge is for, because that's a phase 1, a 21-day detoxification protocol. And based off the patient's labs, you'll be able to develop a phase 2. And by the time they get done with their phase 2, they'll be 60 to 70 days in. And it's time to check our work, so to speak, and make sure that those labs are changing, and then developing the next step based off of those labs. So curating the patient result is kind of like farming, but curating the patient result is a little bit of work, but it's so rewarding. So rewarding.
Okay. I'm going to leave it for others. And
Dr. Zinni, what is the first one in California? What's the name of it? The winery. Empelos. All right. Maybe I butchered that in my Minnesota ease here. So cool. I'll take a note. Thank you for that.
You're welcome. And they've been doing it now for about 10 years.
2008, first certification.
But my wife is in the background. She's telling me it's 2008.
2008 is when we got our certification.
It's great.
And the wine tastes good. It's not your old organic wine. It's actually got a nice flavor profile.
Very good. Cool.
That's the way to end the night, right?
Mhm.
Great seminar, by the way.
Okay, thank you so much,
Thank you.
Dr.
All
Watts.
right. All right. If you heard any
Okay.
fireworks in the background, I apologize. I'm hearing it now, so I'm going to go attend to that. But thank you for having me, Doctor. I
Thank you.
appreciate it.
Thank you so much. And we'll hope you'll come back in a few months again.
Absolutely.
Places, yeah.
Anytime. So
Thank you. Thank you. Thank you so much. And Kim, thank you.
Our pleasure.
Not too much this week on the home front, except for this, Dr. Burgess. If you can you see my screen?
Yeah,
Everybody? Did you see that?
I saw.
Dr. Burgess has been working on a logo for our new entity. This is what we've come up with, and you want to explain it, John?
Yeah, yeah. The three pillars are our ethics, safety, efficacy, cost. The beams coming together in the middle is simply integrated, coming together, like the Beatles come together and join forces. So anyway, that's what the symbol implies, and we are what it says. So it looks kind of neat and gets your attention. But basically, we're pushing ethics, and that's why it looks like this.
So,
Great time.
if anybody has any comments, any questions, any complaints, so we're sort of moving along. We're following the guidelines that we've been given, and we're doing it one step at a time. So it's about all I have to share with anybody this week. Otherwise, it's been pretty quiet on the home front. And anybody have any comments, questions? And our
So I'm not
A
I'm not an
reminder.
art.
Oops, sorry. I was going to say a reminder to our speakers, I think by when, Bill,
September
mid-September,
15th,
the recordings are due via Zoom.
right?
So back to the picture. I'm not an archaeologist, but I think those are possibly Roman caps on the pillars. And if we want to go back to our Hippocratic Greek oaths, then you probably want to have something that's maybe more Grecian.
We can do that. We can alter this, affect it, modify it any way anybody wants. We even had another suggestion, which was a good one, that we turn these pillars into trees, big trunks of trees like sequoias, but still get the idea of three entities. And we can change it to Greek if you like also.
What if you put the words on the pillars?
We're keeping it simple. This is just to punch them in the face and let them get the idea. We'll take it with Roman, Greek, trees. We just needed a symbol to get their attention, and that's what we got for now. But since we own it, we can do whatever we want. So that's a good suggestion. And the reason for pillars in the first place was to give it a little bit of that ancient, just honest touch, like you're talking about.
Now, pillars are perfect.
Support, and they support our idea of coming together, and that's all we're doing.
Amen.
Okay, so like I said, we're moving along, and having, little by little, we're getting to where we need to be. We'll have to have a formal meeting sometime soon, probably in the next month, and we have to have an election of officers. We can make suggestions like we've done in the past, but if anybody's interested, please let us know. And so we're also looking for anyone to help out. can help with these seminars every week. I'd like to see a newsletter at least once a month or once a quarter at least developed. We're working with Age Management Medical Group to come up with a core competency in integrative medicine for us. So those are the fronts that we've been working on. I'll leave it open to the floor. And if anybody has any comments or questions, let us know. And if not, we'll see you next week. Our own Ron Centric is going to be speaking about depression next week. And 2 weeks, I'm not going to be here. I'm going to be visiting the grandbabies, and I'll be traveling during this time. So I'm going to need somebody to host and run the show. We have Dr. Felice Gresh that night.
On vacation
So-
for the rest of the week.
So
Are any of you,
Right.
clinicians getting involved with the ivermectin plus lactoferrin trial to treat prostatomegaly and prostate cancer?
let us know what it's about.
Yeah, okay.
I don't know. I've never heard of it.
Yeah, it's a very interesting one. I found some Indonesian researchers who are doing this one, and I have a patient interested, so I'm going to do that for him.
Okay, if you can give us get us some information. You want to give us a talk on it?
Yeah, I'll tell you the results. We're going to do it for 40 days, and we're going to track his PSA and see what happens.
Okay, well,
Put it
that'll be perfect. You know why? Because our next opening is I think it's October 18th
All right, cool.
as our, no, I got somebody for October 25th.
Yeah,
So
We'll
if I
see
put
what
you
the
in there, that'll give you enough time.
Yeah, yeah.
Okay, you're on.
All right.
Okay. So, and what is it again? You said ivermectin and,
It's ivermectin plus lactoferrin, and you do that for about 40 days and see if the PSA drops.
okay.
What dose are you going to use?
You said dose 250 milligrams of lactoferrin and the 0.3 milligrams per kilogram of ivermectin.
Thank you.
Okay, so we can all try it out, right?
If you have a
And-
large prostate, why not?
And what about before and after MRIs?
Yeah, he's had an MRI before. He's had a biopsy before. He's had a PSAs done over the years. So a lot of good information on this.
Yeah, maybe an afterwards MRI or ultrasound, something to show size of the prostate might be
Yeah.
interesting.
Yeah, we can get that.
Cool, very cool. Very
Okay,
interesting.
Stephen, I have you on for October 25th. This is how you end up volunteering.
Okay, cool. I'll have something for you.
And that'll give you more than 40 days.
Yeah, good.
Okay. Okay, guys. Anybody else? This is how you get roped into it. So, okay. Any questions, comments? And if not, I'm going to say goodnight, and we'll see you next week, same time, same station. Ron, if you're still on, you're up next.
Okay,
Okay, we're looking forward to it.
all right.
Okay, thank you all. We'll see you next
Thank you.
week. And I'll get the video up and the slides as soon as I get them.
Bye, everybody.
Thank you. Good night, everybody.